Hi, welcome to Self Perspective. Today, our guest is Matt Mazurek. Matt is a physician. He is an assistant professor at the Yale University School of Medicine on the faculty of anesthesiology. Matt, it's good to see you again. Welcome.
Yeah, thank you very much, John. And I really look forward to this opportunity. I really appreciate this. So thank you for inviting me.
Tell us a little bit about your story. You're now at Yale, but how did you get to Yale? We met and you were in the northern hinterlands. So why don't you share a little bit of your story with us?
Well, I was born and raised in Fresno, California, originally going to be an astrophysicist. Switched to English literature, creative writing, and poetry, and had a series of professional and personal experiences that steered me towards medical school. I applied to UCSF. I enjoyed physiology, anatomy, pharmacology, and decided to do anesthesia. So completed my residency there at UCSF and then moved back to the Southwest to pursue astronomy as a hobby and also just work as a private practice physician. I wandered into leadership. So I volunteered to be on committees for our department at the local hospital, St. Mary's. And one thing led to another. I was elected chair, really enjoyed that, and then wanted to make further contributions and became chief of staff at St. Mary's almost 10 years ago. So that really kind of catapulted my interest in leadership, some of the inner workings of medicine, how the business side of medicine works. And I eventually applied for a medical directorship with Envision Physician Services in Minnesota. And
was that your first experience with corporate medicine?
Yes, absolutely it was. So
without taking an axe to Envision, what was your expectation and what was the reality?
Well, when I first joined Envision, it was a newly formed company, AmCare and Sheridan merged and AmSurge merged together. There was a lot of excitement, and I did get a lot of opportunities within the company to help with, quality committees, et cetera, et cetera. Of course, we were isolated up in northern Minnesota. We were one of the only sites, and our nearest, sister site for Envision was in Wisconsin. So, but the support was really, really good. As soon as COVID hit, though, I think that's when, unfortunately, we lost the contract up there. So I had to pursue other opportunities.
So you are a very active poster on LinkedIn. And some of your posts are really pointing to what a lot of people see as an emerging dark time in the practice of medicine and in healthcare in general. Why don't you kind of give me a little bit of an overview of your beliefs and what you're trying to accomplish with your post?
Well, I think that there's been a dramatic shift, frankly, in what delivering medical care has transformed into from what it once was 25, 30 years ago, even when I started medical school. I think that a lot of the people who were providing that care and had interest in the care at that point in time were really wanting to make the system better and provide better service and access to patients. And I think that as the corporatization of medicine, I hate to use broad terms, but that's the accurate term for it. I think that some of those interests have now been put to the side, and there's been much more of a pursuit of profits over actual healthcare delivery. So, I aim to kind of point that out. And unfortunately, I think it's that creep is now even seeped into some of the larger nonprofit systems, for example, where they used to be more community oriented. Now they're part of larger health systems, and their behavior has been mimicking a lot of the for-profit systems as well.
Back in the 80s, when I was doing a lot of work with rural community hospitals, in Texas, we had the Corporate Practice of Medical Act prohibition against hiring physicians. Eventually, we worked our way around it by creating something called an A corporation that was controlled theoretically by physicians. The problem back then was we kept thinking in these rural hospitals, which couldn't really, they didn't have the size to do an A corp. It's like, gosh, if we could just hire physicians, it would be so much easier to recruit. And a lot of these hospitals had aging medical staffs. The competition for family physicians or internists was really, really intense. Now it seems like we weren't careful about what we prayed for. And now that some of the law of unintended consequences seem to be revisiting us with a vengeance. Tell us a little bit about your take on what's happening with private equity and how they are possibly threatening really the whole kind of culture of healthcare.
Well, private equity in healthcare, one has to realize what private equity's aim and goal really is. And you can't forget that regardless of what sector of or industry in which they're operating. For example, I know that, my former employer Envision was purchased by KKR, which is private equity. And these organizations, of course, sometimes are saddled with an enormous amount of debt. So the promises and the actual, delivery on some of those promises with some of the private equity groups may not actually come to fruition. And that's been my concern, because private equity, and when you say the word corporate, it's who is the they in the whole mix. And I think what's happened is we've transformed the entire healthcare system from individually, locally owned, hospitals and private practice groups that work in tandem to serve the community, to larger systems and owned by private equity that now are looking for either shareholder or investor value first, and the patients and the physicians and the hospitals, et cetera, are a means to that end. So I think that the decision-making processes are not always in alignment with what's best for the communities and the patients with whom they're serving.
I ran into an anesthesiologist at Starbucks in the wealthy enclave of Highland Park in Dallas one day, and we were chatting. And this was probably 5 or 6 years ago, and he was talking about how his life had changed. And I had known him from Starbucks, and I said, Dr. Williams, how has it changed? And he said, we were a very successful physician-owned group, and we had some great contracts, and we absolutely, we made good money. We all worked very hard, but we took time and we played hard, but we worked hard, and we all had great incomes. He said, then some of these younger people who went off and got their MBAs started pushing for how to maximize for them to be able to maximize equity in the practice. And they got really absorbed with that, and finally pushed through, much to my chagrin, he said, an acquisition by a private equity group. Mm-hmm. And he said, suddenly we had so much debt. We had no debt. We had so much debt, and we were struggling. And so then they sold our buildings to a REIT, and we leased them back at an exorbitant rate. And he said, this year they've cut our income because our debt to service the debt. He said, my income has been cut almost by half, and I'm looking at personal bankruptcy. And he said, in 3 short years, I've gone from well on my way to having a comfortable retirement to today thinking I'm going to have to declare bankruptcy. Is that a common story, or was his an exception to the rule?
Well, I'm not quite sure if the economic implications of that really are a common story, but what I can say is with especially in anesthesia and emergency services now, the larger corporations, if they win or lose contracts, it's highly disruptive to the individuals who are working at those facilities. For example, when we lost the contract up in Sanford, for example, now in the middle of COVID in 2020, I found myself running around the nation looking for, other employment alternatives. Of course, I was going to reapply there at Sanford Health, but I didn't know what kind of a compensation benefit package arrangement, et cetera, what was going to be offered. You simply can't you have to look out for your own self-interest. And I think what's happening is, because there is so much turmoil, the executives in the C-suites are putting out RFPs. Some of the private equity companies are pulling out of areas where they're not making the return on investment that they thought. And you don't know which way that wind is going to blow you over from. And so my my advice to all the residents now, of course, is have an exit strategy even before you start. That was not something that I think was really thought of 20 years ago, 25 years ago.
It wasn't necessary.
It wasn't. No, I never intended to leave Tucson, for example. But I also wanted to work with CRNAs, and that's why I left my old group, because half the group didn't want to, basically start working under a different kind of anesthesia care delivery model. So, I mean, it's basically chaos out there right now in medicine, and no one is landing on their 2 feet on solid ground. I mean, you're frankly at a sandy beach no matter where you land. So
I deal with a lot of executives and managers in some positions who are going through career transitions. For the physicians, it's such a strange experience, because that was not even on their radar screen. They had no idea how it works. They had no idea what to expect, but they know that they now had to make a change. What are you telling young residents? I tell the older physicians, just be very careful. The people come to you with opportunities that the people by your side are not necessarily on your side.
Right.
What are you telling the residents today? Is they prepared to be courted, wooed, and wined and dined?
Well, first of all, most are going to be employed. There are a few who have found some landing spots in private practices here and there, but a vast majority of the residents, now that's the exception, not the rule, whereas employment used to be the exception. So what I basically tell a lot of the residents, you're entering into a corporate employer-employee agreement. You're not partners. So get rid of the idea that if you're going to be employed, you're a partner of the corporation. You're not. You're an employee. So that means you have to approach searching for that job and then also negotiating your contract as a future employee in a much different manner than you would if you were doing it with the local group. So, and I think there are a lot of pitfalls, because I think local groups really are very, very interested in usually retaining talent and recruiting top talent, and they're invested. They don't want you to leave. It's the same thing with an employer, but that relationship is certainly not nearly as personal as it is with the local group. So what I do tell them is, remember, human resources is there to protect the corporation, not you. So that it's a trust but verify, and always make sure that all your I's are dotted and T's are crossed with these employee-employer arrangements.
What is your thoughts about those very onerous non-compete clauses?
Well, I think they should all just be done with. I mean, it's a way for them to really put a stranglehold around a physician and keep them in sometimes real toxic working environments, et cetera. So I think it's a setup, honestly, to abuse physicians. And we don't have any secret sauce, especially anesthesia and other hospital-based services, RADs, ER, intensivists, pathologists, a lot of us who are, hospital-based. I mean, we're very mobile. I mean, I could, quit tomorrow and start somewhere else if I was credentialed next week and, in the middle of nowhere. So a non-compete, you want to keep people locally. And I think some of the non-competes have restricted access to care in the local communities. And I think that's one of the reasons why they're being eliminated. Here in Connecticut, I believe the non-competes are now really not even being enforced.
Several years ago, as the A corporation and the integrated health system swept across America, and in particularly East Texas, where I was working at the time, there was this sense that we now we've acquired all these practices. We own them. Why aren't they doing what we tell them to do? Is that is that still an underlying problem that you see in terms of the physician, hospital, health system relationship?
Well, local groups had a vested interest in working hard because they got to take home the extra fruit. As an employee, either of a hospital system or private equity group, most physicians are salaried, and the work hours are not necessarily self-regulated. We're told what to do, how to do it a lot of the time as an employee. But I think too, without that agency and without that autonomy and pride of ownership, the statistics are out there already. Employed physicians have been less productive than they were when they were in their own private practice groups. And it makes perfect sense because you're a small business owner. When I was in Tucson, when I was part of Southern Arizona Anesthesia, for example, I was a business partner shareholder of a very large and successful small corporation. And there's a lot of pride in that. And, I do miss it, to be honest with you. I really do. I had agency, I had autonomy. All we had to do was answer to ourselves and serve our patients, our surgeons, and our hospitals, and with excellent service.
And if you didn't do it, they would find someone else who would.
Correct. Yeah, we took ownership of everything. We took ownership of the good. We had to also take ownership of the bad. And as an employee, do you really have to take ownership of it? I mean, it's not to the same degree. It's just not the same. I mean, it's that cog in the wheel effect that corporations create. You're now, when I was, for example, I never felt like I wasn't valued within Vision, but I was one of thousands upon thousands of employed physicians. So, my absence is not going to really be felt across the organization. Whereas 2 or 3 partners in Tucson disappear locally, all of a sudden we're in a world of hurt. So
several years ago, I was visiting with a newly minted physician MBA, an orthopedic surgeon, and he made this interesting observation. And it wasn't so much political, but he was using a political context to explain his perception. He said, when I, as a private physician for all these years, I always kind of identified with the Republican Party because they were about capital. And he said, now physicians are more about labor, and that we are almost assembly line, cogs in the assembly line. And he said, it changes your perception. We're also now hearing and seeing signs around the country of physicians talking about forming labor unions.
Yes.
Primarily, a lot of that may be with the residents, but that's an interesting phenomenon. Tell me your take on that.
Well, as a former Teamster, 3 days after graduating high school, I was paying union initiation dues when I had a job up in Yosemite Park. And I will tell you, one of the most impressionable events that ever occurred in my own life was when I was about 9 years old. My father was a teacher for Fresno Unified School District. He was part of FTA. They went on strike for 2 weeks in the late 70s. I don't remember particularly what the issue was. That's not really as important as the fact that my dad walked the picket line. He pulled us from school, my little brother and I, so it did have an impact on us directly. But the fact is, the strike ended and they accomplished their goals. So unions are only formed when there is a grievance, either with compensation, working conditions, or benefits. Usually it's one of those top 3 categories. Now, resident physicians, of course, especially in large urban areas, their salaries are not keeping up with the living expenses. And despite the work hour restrictions, most are still working around 80 hours a week. So there is a lot of work, and I don't know necessarily that the compensation is reflecting that work. So I think a lot of the resident physicians are feeling this need to collectively address some of these concerns. And I think it's going to spill over as they become employees. In the next 5 to 10 years, I think there's going to be a huge acceleration in physicians forming unions outside of training programs. In fact, I think it's already starting to take off.
It's astounding. Which union is taking the lead on that?
I believe, well, I don't remember the specific union name. I know that some of them are under SEIU. But there's the CAIR, I believe, the Committee for or Association for Interns and Residents. That's one of the major unions that the residents are forming or becoming a part of.
That is, and I'm not making an anti-union comment here, but that sort of union organization, that sort of a need to organize because our grievances aren't being addressed, our pay is not being addressed, that's extraordinary. And what's the impact going to be on medicine?
It's difficult to say. We still have an access problem, with primary care. I think too that some of these residents are also wanting to form unions to address some of the social determinants of health. They want the healthcare systems to start, recognizing that there needs to be some actionable policies or programs to really kind of embed themselves within the communities. This younger generation. It's easy for us older folks, Gen X and boomers, and even some of the later millennials to kind of, I hate to use that word, bash the younger generation. They are growing up with a whole different set of tools and perspectives and technology and information that you and I, we did not grow up with this amount of knowledge or have this at our fingertips, and they do. And I think, for lack of a better word, they're seeking some form of justice overall. And I think that that's one of the ways in which they want to, produce that form of justice is through a union.
I want to double back for just a minute and talk a little bit more about the acquisition of physician practices. In the 1990s, we saw the rise and unceremonious fall of practice management companies. There was a big one in Tennessee that was a bunch of HCA former executives. There was one that the Health South founder was promoting in Georgia. And then there were a lot that blew up all over the country. And many of those failed spectacularly, wiping out physician retirement plans. And physicians had invested in those practices. And instead of taking cash, took stock, and pretty much wiped. Some of them were wiped out completely and had to really start all over with their retirement program. And now we don't have as much the private equity company. It's now more about private equity driven management.
Correct.
It feels like we're moving toward a blow up. It may not be a financial blow up, but it certainly has a social blow up. What do you see happening here now?
Well, I agree with you about the blow up, but the blow up is going to have to come from the patient side of the equation, and the reason I say that is because health insurance premiums have skyrocketed over the last 10 to 12 years, and patients don't have access to timely care. We know about the prior authorization issue. So there's brewing anger towards the insurance companies more than anything else, I think, right now, both from patients and providers. So the blow up, if you will, is going to eventually be a day of reckoning for insurance to kind of get their ship right and not just simply seek as much profit as, that's the only sector in healthcare doing very well right now. They don't have any issues. Hospitals are swimming in red ink. Physician private practices are swimming in red ink. Patients are saddled with debt and expenses, and the percent of income that each individual family now is spending on healthcare expenses is just absolutely insane. So, and part of this is really being driven by the fact that the insurance companies are taking a lot of this profit off the table.
What a great time to be talking about that, since the Medicare open enrollment season just came to a close, and the number of robocalls we've gotten into our house have declined to almost none.
Right.
That's another area that's very frustrating to physicians. Medicare, because they are worried about their current trajectory of spend, although it's down from previous years, that they point to Medicare Advantage plans. And Medicare Advantage plans offer the world, and a lot of the companies are very profitable. The Scripps CEO, Chris Van Gorder, talked about how much money they were losing on Medicare Advantage programs. Is that part of what is driving physician frustration?
From our end, at least, I'm not going to say, especially as employees, a lot of us are payer blind. And again, this is one of the, harken back to what I said earlier about being in private practice. I mean, we had to negotiate our own contracts. And of course, we're very much payer sensitive, because if we have a bad contract, or if Medicare reduces rates, that of course directly impacts our income. Employed physicians are shielded by that unless they actually, kind of poke their nose in and, look under the hood with the corporation a little bit. And the fact that Medicare Advantage plans have been denying claims and dragging out prior authorizations has given some groups, and I know that there's one in San Diego right now, they just want to drop Medicare Advantage altogether. They're just tired of the headache, the administrative burden, etc. So it's, again, those forces at work. Now, if all these companies or organizations start dropping MA plans, where are patients going to go? That's why I'm saying this always circles back to the patients. Where are they going to get their care? So
we're kind of talking around this issue a little bit, but there are certainly a lot of reports out there that show that physicians are frustrated. They're really exhausted. Physicians say they go home at night and work. They go to bed and work with their laptop till 10 or 11 o'clock at night, just trying to get caught up on the paperwork.
Right.
That they are really have so limited time with their patients. They feel like somebody's standing out in the hall with a clipboard and a stopwatch, measuring their productivity. And many are retiring early. Not, many is a subjective term, but a lot of physicians are either talking about retiring early or have retired early.
Yes.
Just exacerbating the shortage, certainly in certain specialties, primary care included. What can we do to try to address the satisfaction issue?
Well, again, money's the answer. What's the question? Physicians should simply have scribes next to them in all of their care areas, because
is
what's
AI
happened,
going to take care of that?
I'm hopeful that if we're talking with a patient, and let's say, if I was a primary care physician, I basically say in the room, I'm going to put you on lisinopril or hydrochlorothiazide for your blood pressure. We'll do a follow-up appointment in 2 weeks. And then something from AI generates that prescription just from what I've just said to that patient at that point in time, and also integrates it into the EMR as part of a note. So the problem is right now, there's so much duplication of tasks and redundancy within the EMR. The 60% of a physician's time now is spent just typing away on a computer. We've become data entry clerks, and I think that's what's happened to a lot of physicians. They didn't sign up to sit in front of a screen. Now, this is where the younger generation, though, this is what's kind of fascinating. It just doesn't bother them as much because they've grown up with it.
But how does that affect the quality of care? Because medicine, the old saying is, you get out of medical school, finish your residency, and you're a doctor. After you've practiced about 10 years, you become a physician.
Correct.
Because it's all about, there is the practice of medicine and there is the art of medicine. How does the reduced face time with the patient benefit?
I don't think it is a benefit. I think we've gone backwards, to be honest with you. because those relationships that we once had with a local physician, for example, I mean, I remember this even from the 80s. I had the same pediatrician from age 3 to age 18. That was 15 years. That doesn't even exist anymore. The system doesn't even allow it. So if you think about that from a quality and a care perspective, this physician who has known someone for a decade or a decade plus is able to tailor their treatment to what the past has been like, et cetera, et cetera. So this, I call it this urgent care click box type of medicine, this minute clinic thing, and it's not real care in a traditional sense. It's taking care of smaller issues, but it's not really, building a trusted relationship. And I think and that lack of that is also giving rise to a lack of feeling of community. Physicians, if they don't have relationships with their patients, how do they feel as much value? So we're going in the wrong direction in many ways. And I just don't know if we can put that genie back in the bottle.
So what do we do? I mean, if you're going in the wrong direction, usually there is a conflict and some sort of explosion. What is that going to look like?
Frankly, I want to, at this point in time, and I haven't done my digging yet, but I want to see where AI takes us. I think AI is going to be just as revolutionary as the EMR. My fear is, though, just as the internet has been a force for good, there have been some real negative aspects of what the internet has brought. And, same thing with the electronic medical record, as revolutionary as it has been, there were some unforeseen issues with it that we didn't think about. We thought that it would reduce a physician's paperwork and burden. It increased it by 3 or 4-fold. Who would have thought that?
So you get to teach residents and supervise residents in your facility. And so you obviously, it's not just about talking about how to do cases. You're also talking about the practice of medicine. What actionable advice are you sharing with these young residents about going through the process? Because there's a shortage of anesthesiologists, there's a shortage of pediatricians, there's a shortage of family physicians and internists. And there's a lot of pressure. And I have people who are executives, and they said, I get a call, and 9 times out of 10, the call from a recruiter is wanting me to and go back into practice. What do you tell these physicians? I did executive search for 27 years. I did physician search before that, and I can tell you that is a whole new can of worms.
Well, if I get a chance, and I usually do throughout the day, especially if it's a new resident I've worked with, I get out a pen and paper, and I basically give them like a 2 to 3 hour mini MBA on how healthcare works and what the different employment arrangements are. It's basically, I tell them, you've got a lot of options. You can stay in academia. You can be employed by a hospital, employed by a large hospital system, employed by a large, multi-specialty national physician group like Sound or Team Health or Envision, or you can join a private practice. And in anesthesia, forming your own solo practice now, it's a pretty uphill. It's an uphill battle, frankly, in this environment. I don't really suggest doing that starting out, but I tell them under all of these different arrangements, there are pros and cons. The nice thing about being an employee, and I tell them this, is it's turnkey. You don't have to worry about overhead. You don't have to worry about a lot of things. You go in, you go to work, and you go home. So what you're looking for in that practice is, does it suit your lifestyle? Are the work hours reasonable? Are your colleagues supportive? Is the kind of practice that you want to do taking place in that particular location? So you still have to seek out the truth, though. And I always say there are some interview questions that you have to ask all of these folks, regardless of where it is and what it is. And the number one thing I say is, don't be afraid to ask about turnaround time or turnover. Any place that has high turnover has a major
There's a
problem.
reason. There is a reason for that.
Yes. And it is a major red flag if they can't reasonably explain a history of high turnover without a lot of hand wringing. Then that you're walking into a situation where they're hiding the rotten fruit. Your job is not to take that job and then find out where it is and then realize you've made a huge mistake. I did this in one of my interviews about 10 years ago when I was searching for another opportunity closer to home in Fresno. I asked, what's turnover? I said, how many people have left in the last 6 months? 6 people had left. The group's about 40. I mean, that's the percentage there is incredibly high. And then I said, well, what about the last 5 years? So,
That must have been a big number.
Well, it actually was. And I found out that the board of directors was the same board for the last 15 to 20 years. And so I had a feeling that there was a lot of economic shenanigans going on behind the scenes, and, schedules weren't as promised, et cetera. And I wasn't about to walk in and discover a bait and switch. So
that's very common, unfortunately. How you tell young physicians to explore the culture, because the culture kills strategy, kills compensation, kills the quality of the community every time.
Well, first of all, I think the best way to do it now, I've done Zoom interviews and I've done on the ground interviews, and Zoom is not a good way to get a feel for culture at all. It's terrible. Frankly, it's terrible, because you just don't get a real feel for the place. So you have to physically go there, number one. Number two, during the interview process, I always tell them to ask these 2 questions, just as I've asked them. Tell me what's the best thing about working here. What do you most enjoy? And ask that to everyone. And if you find a good, consistent answer that basically, demonstrates a good culture, then you can start believing it. The flip side of that coin is, I never say, don't ever ask what's wrong. Just say, if I was to walk randomly down the hall of the hospital, etc., if there was one thing that needed improvement, what would it be and why? It's asking what's wrong without asking what's wrong. And it's a brilliant way to find out, potential cracks. The other thing too is, I think it's critical, especially for leadership positions, but what's the relationship of the particular practice or group with the C-suite executives? Do they get along with the chief executive officer, the COO, CMO? What does the chief of staff have power there too? So I think that answers to those questions reveal whether or not there's a really good, partnership culture. So, and you can ferret it out very quickly. I had one interview. I asked the chair of surgery what he thought of the CEO, and he went off, said our relationship with the CEO is terrible. Well, thank you for playing. At the end of the interview, they wanted to move me on. I said, no, I'm good, thanks. I found out right away that, again, that there wasn't a good culture.
We're getting ready to start the infamous recruiting season.
Yes.
Yeah, it's already, some people, are already some have already made decisions. Some people, there's no national signing day for physicians. Do you see this crop of physicians that's coming out today that you're rubbing elbows with at Yale? Do you see them as making a difference or being go along, get along?
They're going to make a difference. Now, I'm probably very biased, though. The trainees that I've worked with here at Yale are a pretty exceptional group. They're exceptionally talented. We're looking at, people who are exceptionally accomplished. Some have had their own businesses, some have been in investment banking, some have published books, done research. These are real solid residents, and a lot of them are going to do fellowships. Some are going to go into private practice, but they're really, really hungry to learn about leadership and make a difference from our generation. And that's why I've started that curriculum here at Yale for our department. Specifically, we had a meeting this last Wednesday here, and there were about 43 of the students crammed into a room. And they were just eating up what Dr. Rosalinski and I had to say about all of this. So they do want to make a difference. I think they just need to be shown how to do it. And that's what my job is to kind of show them a little bit of what the road ahead can look like.
Wrapping up today, we've been talking about for years about how healthcare is going to emerge into this transformative era, and we don't seem to have found the keys to the door. As we look at some very bad things that are happening in healthcare now, some not very good trends about manpower, both nurses and physicians. The number of assaults against nurses and physicians is going up dramatically. It's as if somebody made an announcement and said bad behavior is okay because it's all big conspiracy. But what do you think today that the obstacles to really achieving meaningful change in healthcare, what are those obstacles from your perspective?
Well, we need to break down the silos and break down some of the bureaucracy within the system. I think what's stifling innovation and a lot of what we really want to do off the ground, we're kind of bogged down in what I call a 7-layer tiramisu cake of, who do we serve today and what part of this, for example, I brought this point up when I was talking about leadership and quality. I said, you want to do a quality initiative in the hospital, just a local level, right? So you've got to get approval from and buy-in from directors, chairs, chiefs of staff, all the way up to, if it involves any capital investment, the CEO and the board of directors. So you've got a lot of different people in there who have different stakes in the game, if you will. Good ideas can fall terribly flat if those ideas in some places don't give return on investment in the shorter term. They may in the longer term, but I think with the corporatization of medicine, there isn't much patience and there isn't much willingness to take that risk. And non-for-profits are under the same kind of scenario, if you will, with the margins.
How much of that is really financial versus sort of an institutional bias against change for whatever reason?
That's the change management, of course, thousands of books have been written on that too. I think it's a combination. We've always done it this way. I always love that argument. And I said, well, this way isn't really working and we can build a better mousetrap. I think it really is. It's a combination of both, So I think it's imperative for us as physicians and leaders especially is to imagine what the future state can look like and then work backwards from that. Go ahead and leapfrog into that future and then figure out that road. How do we get from here to there? And then really, you can't do it alone. That's the other thing. You're working in teams. Find other people who are just as enthusiastic. That can be a bit of a challenge, but they're out there. And getting these teams getting all the fish to swim in one direction towards a great common goal. It's not easy, but it's worthwhile. And it's the only way you get things done.
One of the things you may remember from our work together is we have a eulogy exercise. Where do you want to end up your career? What do you want to be doing? It'll change, okay? But what do you want to do today? Because there's certain things, if you don't start doing them today, you'll never get to that point. The vast majority of people don't do it. It makes them uncomfortable. And yet the research shows that people who have written plans for where they want to go and what they want to accomplish with their lives are more likely to achieve those goals versus the people that say, oh, don't worry, I got it right up there. And I think that seems like a challenge that's particular to healthcare. We have this unbelievable resistance to change because we understand how to game the system today. And if we change, we may have to learn some new tricks.
Well, plus there's there's risk. Some organizations can afford to take these risks financially. Other organizations, I'll just throw this out there. Rural hospitals can't afford to play around. They're on razor thin margins. And if they have an initiative that requires extensive capital that falls flat, it's the end of the organization. The larger for-profit systems, HCA, for example, it's got an enormous, amount in its coffers to experiment with different things. And it can afford to be innovative and try new things. So, but, are they really doing that? It's like that map that I've showed on LinkedIn, the US healthcare system. I think you've seen it too. Okay, here's the system. We need to fix this. Now, where do we start? You don't just throw a dart at the map. But I think, honestly, where we do start is just starting to get back down to the basics. I think Atul Gawande, I heard this recently. He said the US healthcare system is like Star Trek technology built upon a Flintstone and Pebbles foundation. We don't have the basics down. We haven't really even addressed trying to create a good foundational care system in this country with primary care, OB, women's, mental health, and children's services. that's the backbone of any good healthcare system, and we're not investing in it because guess what? It just doesn't make much money. The new robot down the street for your prostate surgery just has a lot more whiz bang, and that's where the money goes.
Thank you so much for joining
Yeah.
us today, and I hope
Thank
that you'll
you.
come back and visit with us again.